Antifungal agents are specialized drugs designed to selectively eliminate fungal pathogens from the human body while minimizing toxicity to the host. Unlike bacteria, fungi share many cellular similarities with humans, making it challenging to develop drugs that target fungi without affecting human cells. This similarity means that antifungal drugs often come with side effects, but their role is crucial in treating infections such as athlete's foot, ringworm, and thrush. Antifungals work by exploiting subtle differences between mammalian and fungal cells, and their use has become increasingly important as resistance to these drugs grows. Antifungal agents are not only used in medicine but also in everyday life, such as controlling mold growth in damp environments. In clinical practice, they are essential for treating a variety of fungal infections. However, the increased use of antifungal and antibacterial agents has led to the development of drug resistance, making it more challenging to manage infections. Understanding how these drugs work and their limitations is key to effective treatment and prevention of further resistance. Antifungal agents can be grouped into three main classes based on their site of action: azoles, polyenes, and flucitocin. Azoles inhibit the synthesis of ergosterol, key component of fungal cell membranes. Polyenes interact with membrane sterols, disrupting cell integrity. Flucitocin inhibits macromolecular synthesis within the fungal cell. Each class has unique mechanisms and clinical uses, and understanding these differences helps guide effective treatment choices. Fungal resistance to antifungal agents can develop through several mechanisms. These include alterations in the drug target, changes in sterol biosynthesis, reduced concentration of the target enzyme within the cell, and overexpression of the drug target. As resistance becomes more common, clinicians must be aware of these mechanisms to adjust treatment strategies and select the most effective agents for each patient. Main antifungal agents used in clinical practice include polyenes, flucitocin, azoles, and echinocandins. Each group contains specific drugs with unique properties and indications. For example, azoles include fluconazole, itraconazole, voriconazole, posaconazole, and isavuconazole. Echinocandins such as caspofungin, micafungin, and anagulafungin are also important in modern therapy. Polyenes are natural products derived from Streptomyces nodosus, a soil actinomycete. The most well-known polyene is amphotericin B, which is available in several formulations, including the original deoxycholate and near-lipid-based versions. These lipid-based formulations were developed to reduce toxicity and improve tolerability, making them more suitable for clinical use. Polyenes work by interacting with sterols in the fungal cell membrane, forming pores that lead to cell death. Amphotericin B is available in several formulations, including the original deoxycholate and two lipid-based forms, liposomal amphotericin B (LAMB) and amphotericin B lipid complex (ABLC). Due to its poor oral bioavailability, all formulations are administered parenterally. The drug's long half-life allows for daily dosing, and its distribution throughout the body makes it effective for systemic infection. Amphotericin B is one of the most potent antifungals, active against a wide range of yeast and filamentous fungi. It is effective against Cryptococcus, most Candida species, and many dimorphic fungi. However, some species like Candida lusitanii and Aspergillus terreus may show resistance. Despite decades of use, acquired resistance to amphotericin B remains rare, making it a reliable choice for severe infection. Amphotericin B is widely used for severe fungal infections, including cryptococcal meningitis, candidemia, and invasive candidiasis. It is also recommended for initial treatment of many endemic fungal infections, especially in patients with life-threatening disease. Lipid-based formulations are preferred for organ transplant recipients and for treating mucormycosis. Importantly, amphotericin B is the drug of choice for mycoses in pregnant patients due to the teratogenicity of triazoles. Flucitocin is a fluorinated pyrimidine that acts as a pyrimidine analog. It is imported into fungal cells and converted to fluorouracil, which impairs nucleic acid synthesis and disrupts protein production. This unique mechanism makes flucitocin effective against certain yeasts, but resistance can develop quickly if used alone. Flucitocin is highly bioavailable, with oral capsules being the only formulation available in the United States. Due to its short half-life, it is dosed 4 times daily. The drug is primarily used in combination with amphotericin B to prevent resistance and enhance efficacy, especially in the treatment of cryptococcal meningitis. Flucitocin is effective against many Candida species and Cryptococcus, but resistance develops rapidly when used as monotherapy. It is not active against dimorphic or filamentous fungi. Resistance is often due to decreased drug uptake or mutations in enzymes responsible for converting flucitocin to its active form. Flucitocin is a first-line therapy for cryptococcal meningitis, always used in combination with amphotericin B during the induction phase. While it shows activity against most Candida species, its use as a single agent is limited due to rapid resistance. Combination therapy helps prevent resistance and improves treatment outcomes. Azoles are a major class of antifungal drugs, divided into imidazoles and triazoles based on their chemical structure. Imidazoles include clotrimazole, ketoconazole, and miconazole, while triazoles include fluconazole, itraconazole, voriconazole, posaconazole, and isavuconazole. These drugs inhibit ergosterol synthesis, disrupting fungal cell membrane integrity. Newer triazoles have improved safety profiles compared to older azoles. Fluconazole stands out for its low molecular weight and high water solubility, resulting in excellent bioavailability. It is available as both oral and intravenous formulations, with dosing unaffected by the route of administration. Its long half-life allows for once-daily dosing, making it convenient for patients. Fluconazole is active against many Candida species including C. albicans and C. parapsilosis but not against C. cruce. It also works well against Cryptococcus neoformans. However, its effectiveness against dimorphic fungi is limited, and it is not active against Aspergillus or mucorales. Resistance can develop, especially in certain Candida species. Fluconazole is a first-line treatment for mucosal candidiasis, including in patients with HIV. It is also used for vulvovaginal candidiasis in non-pregnant women and for mild to moderate pulmonary cryptococcosis. Its ease of use and safety profile make it a common choice for these conditions. Triconazole is available as a capsule and an oral solution, with absorption varying between the two forms. The capsule is best absorbed with food and acidic beverages, while the oral solution has superior bioavailability and is not affected by food or gastric acidity. This flexibility allows for tailored therapy based on patient needs. Triconazole is active against most Candida species, though higher mics are seen with C. glabrata and C. cruce. It also covers dimorphic fungi and many Aspergillus species, but has limited activity against Fusarium and mucorales. This broad spectrum makes it useful for a range of fungal infections. Triconazole is approved for treating various mycoses including blastomycosis, mucosal candidiasis, and histoplasmosis. It is also used for empiric therapy in neutropenic patients and as a second-line agent for aspergillosis. For severe infections, amphotericin B is preferred initially, with itraconazole used for step-down therapy. Voriconazole is available as an oral tablet, oral suspension, and intravenous solution. Its bioavailability is high and absorption is optimal in the fasted state. Loading doses are recommended to quickly achieve therapeutic levels, and the drug is dosed twice daily due to its shorter half-life. Voriconazole is active against many Candida species including some fluconazole-resistant strains. It also covers Cryptococcus, dimorphic fungi, and most Aspergillus species, including those resistant to amphotericin B. Additionally, it is effective against Fusarium and Cetosporium species, though not against mucorales. Voriconazole is approved for invasive aspergillosis, esophageal candidiasis, and other severe fungal infections. It is the drug of choice for most invasive forms of aspergillosis, including sinusitis and brain abscess. It is also recommended for infections caused by Cetosporium and Fusarium species. Hosiconazole is available as an oral suspension, delayed-release tablet, and intravenous solution. Absorption varies between formulations, with the oral solution best absorbed with high-fat meals. This flexibility allows for tailored administration based on patient needs and clinical situation. Hosiconazole is active against most Candida species including some fluconazole-resistant strains. It also covers Cryptococcus, dimorphic fungi, Aspergillus, and several mucorales. This broad spectrum makes it valuable for both treatment and prophylaxis of invasive fungal infections. Hosiconazole is approved for oropharyngeal candidiasis and as prophylaxis against invasive fungal infections. Clinical trials show it is as effective or even more effective than fluconazole or itraconazole for prevention. Its broad activity makes it a preferred choice for high-risk patients. Civuconazonium, the prodrug of isavuconazole, is available as an oral capsule and intravenous solution. Unlike other azoles, its IV form does not contain sulfobutylder bicyclohextrin, making it safer for patients with renal insufficiency. It has a long half-life and is dosed daily after a loading period. Civuconazole is active against most Candida and Aspergillus species, as well as Cryptococcus and dimorphic fungi. It also covers some Cetosporium and mucorales species. Isavuconazole is approved for the treatment of invasive aspergillosis and mucormycosis, making it a valuable option for severe infections. Echinocandins are a class of semisynthetic lipopeptides that disrupt the fungal cell wall by inhibiting the synthesis of beta-13 glucan. This action is fungicidal against Candida species and fungistatic against Aspergillus. The three main echinocandins are caspofungin, micafungin, and anagulafungin. Echinocandins are highly effective against many Candida species including C. albicans and C. glabrata. They are also active against Aspergillus, though their effect is fungistatic. Resistance is relatively low, but rates are increasing in some species. Echinocandins do not cover Cryptococcus, dimorphic fungi, or mucorales. Echinocandins are recommended as first-line agents for the treatment of candidemia and invasive candidiasis. They are also used for prevention and empiric treatment of fungal infections in high-risk patients. Their safety and efficacy make them a cornerstone of modern antifungal therapy.